Okay, it's 3 o'clock, so I'm going to go ahead and have people start introducing themselves. I'm sure we'll get some more coming in as we do that. Let's start with Aimee.
Good afternoon, Aimee Dubs from Health Facilities Planning and Development.
Good to see you. Cherish.
Good afternoon, everyone. Cherish Cronmiller, the Executive Director of Olympic Community Action Programs, your community action agency for Jefferson and Callahan counties.
Thanks. I should have mentioned, if you have any updates that you want to share while we want to hear them.
No, I will share in the chat some links to some pictures of some of our projects that are going on. And if anyone has follow-up questions, also the agency is looking for a new finance director. So if you know anyone who's a CPA or auditor or monitor who would love to live on the Olympic Peninsula and work with me, bring them my way.
Did I hear that you might be willing to have that person live in Port Angeles or?
That's correct. Yes. Either location would be fine. And I'm very flexible, in that regard. We do have a Forks office, but that might be a little bit of a stretch. So ideally, yeah, Port Angeles or the Port Townsend office is great.
Okay. Denise.
Hi, I'm Denise Baker. I'm the Community Health Division Director at Jefferson County Public Health, and I'm formerly the Empowered Teens Coalition Chimicum Coordinator. Thanks.
And pretty soon, I don't know if she's going to be in charge of, the whole state. So just to watch those titles expand.
Only if we're doing it together, Lori.
Chief McKern.
Jim McKern, Cool Scene Fire Rescue.
Good to have you here. Jim?
Jim Novelli, Executive Director, Discovery Behavioral Healthcare. And on January 31st, at 10 o'clock in the morning, we shall be hopefully officially transferring services from Beacon of Hope, Safe Harbor, under the roof of DBH. And it'll, as of February 1st, we will move forward as one whole unit. So excited to say that finally. I hope nothing gets in our way. We're scurrying like dogs to get this finished. So.
Well, congratulations. A little bit early, but congratulations. What this means, one of the good things it means that folks at this table are interested in is that integration of both provider and prescriber services, which we're hoping that's going to then improve generally how our folks access services. Lisa.
Are there two Lisas today?
Are there? I'm sorry. Lisa Grundl.
Hi, this is Lisa Grundl, and I'm with Health Facilities Planning and Development, and Aimee and I have been working on some of the data that we'll be showing today.
Good, we're looking forward to that. Commissioner Brotherton?
Sorry, Greg Brotherton, Jefferson County Commissioner. Happy to be here. Good to see everyone.
Good to have you here. Sheriff Knoll.
Joe Knoll, the Sheriff of Jefferson County currently, and that is until Jim Novelli and Denise Banker might take over the whole county. Good to see everyone.
Good to have you here.
I just need a badge on my vest here, so.
I'll offer my hat. How about Dave Fortino?
Hi, Dave Fortino, Chief of Corrections with the Sheriff's Office. Until Joe's no longer sheriff, I guess.
Lisa Thomas.
Hey everybody, Lisa Ray Thomas with the University of Washington Addictions, Drug and Alcohol Institute, and also the American Indian Health Commission of Washington State.
It's good to see you.
Good to see you.
Kelly.
Hi, good afternoon, everyone. Kelly Parcher, Executive Director of AL 360, better known as the Pfeiffer House.
All right, good to have you here.
Thank you.
James Kennedy.
James Kennedy, Jefferson County Prosecuting Attorney. And one exciting thing that's happening lately is the YMCA got a grant to start a multidisciplinary team for child abuse investigation. I hope that this is going to be one step on the way to developing a child advocacy center here in Jefferson County, but I'm pretty excited about it. A lot of work's gone into this and it was heavily delayed by COVID. And so finally happy to get this thing off the ground.
Well, congratulations. That's big. and needed, really needed.
Definitely.
Anne.
Hi, everybody. Ann Dean. I'm the Dependency and Civil Programs Manager for Juvenile Services here in Jefferson.
Good to have you here, Anne. Matt.
Hello, everybody. I'm Matt Reddy. I'm one of the Jefferson Healthcare Hospital Commissioners. Glad to be here.
I'm always glad to have your perspective here at this table. Anya.
Hi, my name's Anya. I'm a community organizer and an educator and a consultant. I'm also a social worker with experience in substance use disorder policy. And personally, I come from a system-impacted family with an intergenerational history of substance use disorders. So I'm excited to be a part of this conversation today.
Thank you. I'm really glad you could be here. And it was a quick turnaround, the decision for her to be able to get here. So we appreciate her flexibility. Brian Richardson.
Hi, Brian Richardson with Dove House Recovery Cafe. I was actually just telling Lori recently about some funding that we'll be getting from the Healthcare Authority. We're still working on our contract and statement of work and everything, so some yet to be determined, but we're grateful for that.
All right. Jolene.
Good afternoon, Jolene Cron. I'm the Deputy Administrator, Clinical Director with the Salish Behavioral Health Administrative Services Organization.
Thanks for being here, Jolene.
You bet.
Chief Black.
Sorry, you caught me multitasking, not quick on the button there. Brett Black, Fire Chief for East Jefferson District 1 and Port Ludlow District 3, which is basically from the bridge all the way to Port Townsend.
Thank you. You feel lucky you got here with all that space that you're covering. Brian Gleason.
Hi there, Brian Gleason, Jefferson County District Court Behavioral Health Court team member. I think expect emails from me because in the next 3 months, we're probably going to have 3 of our long-term behavioral health court members graduate. So we're kind of excited about some of them because they've made some amazing turnarounds.
That's great. We'll look forward to getting that information. Did I miss anybody before we turn to the agenda that we've got set out for today? Okay, I'm going to share my screen quickly just to give a quick overview of what we're going to try to cover today. We'll talk quickly about the Pfeiffer House. We're going to do a bit of a case study around harm reduction and a reflection, a chance to sort of look through something that unfolded and how we can learn from it. And then we've got, you may remember we presented the data, let's see, I want to say this was back in October for the months going from March through August of this past year. And at that time, we noted that there were some updates we wanted to try to look at. So those have been, we received the data, we've got those updates, and Aimee and Lisa are going to take us through those. And then we'll have a quick update from Jolene on upcoming programs. And then just some quick resources there at the end of the slide. I wanted to, hold on one second, let me just get it so that I can see folks. Thank you for your patience. On the Pfeiffer House, I had intended at the last meeting that we would take a vote and it would be all settled at the end of that meeting. And then with our technological snafus, the good thing was Kelly got to present, and the bad news is I didn't get to take a vote, but I did take one over email. And then I'm just confirming here the votes that I got and confirming that we are voting to approve this. But I wanted to give a chance for any discussion that needed to happen before we show that as approved and I go for a budget amendment. Is there any thoughts anybody has about that project?
Go, Kelly.
All right. With that, we're going to just hop on through that slide and move into our harm reduction reflection opportunity. Jefferson County Public Health and a community member had an exchange that I think gave us something to learn, and I wanted to bring it here and give both parties sort of a chance to tell us what happened and then to walk through the sort of debriefing process I've laid out on this slide. And so I think I'll start by, I'm going to take my screen off for a minute so that we can all see each other. I'm going to start by, you met Anya as we went through introductions. So Anya is on the community side of this conversation, and Denise Banker is on the Jefferson County Public Health side of the conversation. And I thought that to begin with, I might just ask Anya to share what unfolded from her perspective.
Sure, thanks for the time. So last week, my partner went to the public health clinic for a scheduled reproductive health checkup. And currently we have a loved one that's relapsing on opioids, which is very scary. I've been to the syringe exchange program before at Jefferson County Public Health and been given Narcan, but my Narcan's currently expired. It has like 1.5 years, 2-year shelf life. So I asked my partner when she was going there if she could ask for some Narcan, because I know that they have Narcan. And at her appointment, she asked the provider for Narcan, and she was told to come back during the syringe exchange program clinic hours, which was coincidentally like right when she was there. It was kind of ending. She was there around like 12:50 or 12:55, and the clinic ended at 1. And so then she was asked again and told that the nurse was in a meeting, if she wanted the nurse to be taken out of the meeting or to just come back on Friday during the clinic hours. So that was our experience. I was really upset because I think that everybody should be trained in Narcan administration and distribution. And I know from a policy side that you don't have to be a registered nurse to distribute Narcan, that volunteers and the person at the front desk, anybody can distribute Narcan. So I followed up with Denise to share our experience.
Thank you. Now I wanted to give Denise a chance from the clinic side to outline what unfolded from your side.
Yeah, thank you. Thank you, Anya. It's nice to see your face, and I enjoyed our exchanges, and I'm glad that we've been able to come this far. Anya's description of what happened is really pretty accurate. The MA offered to get the nurse out of a meeting, and the patient said, no, we'll just come back on Friday at the syringe exchange time. There wasn't a syringe exchange program happening that day. And if our website is in error, then we need to update that. But there hasn't been since COVID syringe exchange day, save Friday, I believe, since the beginning of COVID. And so so then it was left at that. And then and then Anya wrote to me and I was alarmed by her experience and the distress that had caused her and her family. And so what I did was talked with my supervisor, and we discussed this policy and of not giving out Narcan to just anyone, just when people come into the clinic and just ask the front desk for Narcan. We don't give it out. And to having it just being distributed during syringe exchange program times. And I question the validity of the client being there for a checkup, and they have an appointment and they're there, and why wouldn't we have the practitioner just do it then. And so the upshot of that detail is that what this helped us recognize is that there are, sort of unforeseen, underexplored consequences of this policy that we have. And some of the policy was based on capacity, especially right now during COVID. And at the same time, there was this question of, well, it doesn't take that long to verse someone in how to use Narcan. And there's also a video on YouTube. And also there's, there's an opioid epidemic. And a lot of times there's people who come in and ask for Narcan and they know how to use it already. And so that what it did was it opened up a little bit of a vein so that we could explore this policy that we created in a way that is better informed and more delicately conceived, so that we don't run into this situation again. And so so I really appreciated Anya reaching out, and then she and I had some exchange around this, and that's how I learned that Anya is a consultant and a social worker, etc. And then we thought, my supervisor and I thought about the Behavioral Health Consortium and about South County Harm group, and thought, well, maybe we should introduce Anya to Lori. And so then that's how we shared this information with Lori. So
thanks. So Anya, how did, before you got a response back from public health, but it had unfolded the way it unfolded. Can you take us through how you felt then, and then if anything evolved as the exchange kept going on between you and Denise?
I felt really upset at first, that I felt like my partner who was there was being stigmatized and potentially racism, and that she was being judged and wasn't just given medicine that she asked for that they have. I was mad at the county, listening to Denise's experience too. She was given a paper that had hours of the syringe exchange clinic, and one of them was Wednesday from like 9 to noon. I can forward you that paper that I have a picture of. So I guess there's improper information about when the syringe exchange clinic is even happening, and to learn that it's only happening one day a week because of COVID, when drug overdose is one of the consequences of this public health epidemic. We know that there's been a rise of deaths, like 100,000, over 100,000 people died last year because of preventable drug overdose, with over 70,000 of those related to opioid overdose. And I don't see public health doing anything. I went to their Instagram and their Facebook to see if they were advertising that they have Narcan or that this is a free service they provide. And it just seemed like they weren't really doing anything to be getting this life-saving medicine into the hands of our community members. So yeah, I was just really upset and mad. And I think I was like kind of heated in my first email to Denise, but tried to explain that I'm really scared right now, and just like going through a lot with my family and my loved one, and having Narcan is something that's really important for me, and I think is something that everybody who works in public health or who works in behavioral health should have access to and should carry with them. And so I was just really disappointed to see that our county was lagging so much in this area when we have the resources.
I want to underscore how much I appreciate that everybody's just coming to this and being straight up about how it unfolded and what everybody felt like. It's not easy to look hard at things, and it's not easy to look hard at things in front of people. But I think that we have an opportunity here, and I understand what Denise did next. How was her way of interacting with you? Was that helpful?
Absolutely. Yeah, Denise was very responsive, and I felt like she was taking the situation with the kind of attention that it really deserves. I think because of my background, like having a social work degree and having experience working with people who use drugs and working with syringe exchange clinics, that I felt more emboldened to speak up for myself and to advocate for this. And that than maybe someone who's like deep in a relapse or deep in drug use would. So I was really, really like honored to have Denise's time and for her attention and receptiveness to make time to talk about these things and to remedy them and think of like action plans and things we can do moving forward. So we can have a more urgent response to this really urgent public health epidemic.
I want to step back for a minute. So everybody in the group has just heard two sides. Can somebody, in a nutshell, tell me back what they perceived happened first and then what the follow-on was? I just want to make sure people are absorbing what's being said here. Is there anybody who'd like to give just a quick synopsis of what we've heard?
I had a quick follow-up question, if that would be okay, Lori.
Of course.
Yeah, and Anya, I appreciate your perspective, your sharing. I'm wondering, and certainly if you're not comfortable, that's understandable. And I certainly don't mean for you to have to speak on behalf of your partner. Can you say a little bit more about the racism aspect and how that was perceived by you and or your partner?
Yeah, well, my partner's a Black woman, and so she asked for Narcan and was denied access to it. And one of our other friends who's a Black woman said, I wonder if Anya had gone in and asked for it, I'm a white woman, if I would have been given it. So that's what I mean.
Great. Okay. Thank you for sharing. Yeah.
Thanks for the question, Cherish.
Looks like David has a question.
Yeah, I was gonna say a couple comments. I'm not sure, Laura, I'm up to your teach back. I can try if you want. I think what I hear is a wonderfully brave human, Anya, is relaying the experience of her partner, a Black woman, which I think most of us on this call recognize is a true minority in Jefferson County and frankly in the Olympic Peninsula, sadly, who really felt stigmatized when they had the bravery to advocate for their loved one who's struggling with opioid use disorder, and was sort of told no because of probably some sort of miscommunication or discomfort by a more junior member of the healthcare team who wasn't quite sure what to do and maybe didn't seek enough coaching. And in response, I've heard Denise go out of her way to better explore this and to recognize that policy decisions that kind of make sense to people that write policy, we should probably also include the people that it impacts when we make policy decisions and think about how we can break down barriers around important things like naloxone, since opioid deaths probably outnumber COVID deaths in the Olympic Peninsula. Totally guessing there, I don't know, but I'm guessing. And Anya, we didn't meet because I was late. I'm sorry. My name's David Karlbaum. I'm a critical care physician. I work at Harborview, and I'm the medical director for EMS. So all the pre-hospital providers work under my license in Jefferson County. And I just want to say to you personally, I'm super impressed by your bravery in coming to this meeting of unknown people and chatting, and also for your advocacy for your loved one who's struggling with opioid use. I can't even imagine how challenging it is and how frustrating it was to have this experience, but I'm really glad that you sort of were able to experience that emotion and move through it and turn it into something positive by working with Denise and with Lori to figure out how to turn this into something as an opportunity for improvement across the county to help not only your loved one but others. So thanks.
Thanks, Dr. Karlbaum. Denise?
Yes, thank you, Dr. Karlbaum. And I just want to reiterate that yeah, sorry, yes, it does take a lot of bravery to come and advocate, and on the Jefferson County Public Health part, it also takes a lot of courage and confidence to come to this table and say, hey, look, here's what we learned from having a policy that maybe wasn't as well thought out as it could be. And then Anya has further pointed out that the schedule that we're handing out for SEP is incorrect. You know, so those are two huge things. And then I want to make sure that everybody understands that the PA who was, or the MA who was involved did everything exactly right. She was a huge advocate for making sure that that we gave this Narcan to this person. She was equally upset that the person was asked to come back, and was really advocating for getting the other person out of a business meeting to come and distribute that. So yeah.
Greg Brotherton, and then Dr. Carlbaum.
Thanks. Yeah, I wanted to thank Anya as well. You know, making policies, we're often removed from how it impacts, as others have said. Appreciate your truthing our policy that was perhaps misguided. And I do see on Jefferson Healthcare's website now that the syringe exchange program is still listed as Monday, Wednesday, Friday. So let's yeah, it's an opportunity to get it right and prevent this kind of encounter in the beginning, in the future. We know, you know, with Dr. Carlbaum's work in the harm reduction program in South County, we're absolutely dedicated to getting naloxone in the hands of folks to prevent these opioid deaths. I've seen a person's life saved with my own eyes at our store, and I think that this entire group is absolutely an advocate for that and for equitable access as well. So thank you very much for bringing this to our attention.
And thank you, Greg. Dr. Carlbaum?
I was going to ask Anya two things. One, I guess we and EMS have not probably done a great job of messaging. So there is leave behind Narcan in every EMS vehicle now that the firefighter EMTs can give to patients or families. Also with the Sheriff's Navigator has Narcan, leave behind Narcan, and was the first to give it out. So great job, Sheriff Knoll. And I think with the Port Townsend Police, I'm not 100% sure they've picked it up, but they asked for a few, so that's great. But Anya, how can we do better at messaging? You mentioned going to social media to figure out where you could pick up naloxone or Narcan. And I'm still a novice at Twitter, and I don't even do Instagram. And so could you coach us, like, as an end user, like you're like, oh my goodness, my loved one needs naloxone because they are having opioid use. Where do you go?
Yeah, I mean, I think that the outreach material that I saw on, I think the Consortium's website, maybe a link that Lori shared with me, or public health potentially website, it didn't really feel like it was for people who use drugs or for loved ones of people who drugs. It was kind of like a scary type of thing. And so I think that the marketing should be like to people who use drugs, like, this is for you, we want to help you. And I'm really glad to hear, I heard about the yellow card that's in some of the emergency response vehicles, and I'm really glad to hear that the sheriff's office and that the police department have it. I hope that every car there has it and that every officer is trained in using it. I also know that the VA has, on a national level, has put it in their AEDs, and that's something that I think could be implemented at all of our public schools and public buildings, and in spaces where there's public restrooms, like on Water Street and at Chitsamoka Park and the county parks and the state parks that we have, and that anybody who's like cleaning those bathrooms or is like overseeing those is also trained in Narcan use or Narcan administration. So those are a few ideas. And I mean, I think like also having larger community conversations to like teach people about what Narcan is, like maybe starting with something on Zoom, you know, when it gets safe to do things outside, something, you know, maybe around at the farmer's market or at a place where there's large gatherings. public health could set up and like talk to people about what Narcan is and also pass it out for free. But yeah, I talked to Lori on Monday about a list of ideas that I have that I would be excited about supporting her to help implement. And I'd be excited to talk with you to more, Dr. Caldwell, as well.
Thank you.
Super
Chief
cool
Black.
ideas.
Chief Black.
I just wanted to echo the message that Dr. Carbaum had. And for those of you that aren't aware, Dr. Carbaum controls all the 911 emergency medical services in the county. I report to him, Chief McKern reports to him, and other fire districts that respond to 911 medical calls. And without he's being modest, without his leadership for this Leave Behind Narcan initiative, we would not have it. So thank you, Dr. Carbaum, for having it. It is spooling up as we speak, more or less, and we're still trying to make sure it's distributed throughout the county. And just again, to echo Dr. Carbaum's message, if you have, anybody has, Anya or anyone else, any ideas on how to publicly message this so that we don't miss an opportunity, we're all ears. So this, I think that's one of the productive elements of this venue, is to make sure everybody understands that, sometimes we initiate things, kind of to Commissioner Brotherton's point, that we think are very well intentioned, but we don't necessarily deliver it or message it the best way. So yeah, in the next couple of weeks, we're really hoping to kind of refine our messaging on this. It is for a 911 type event from the fire EMS side. We're not set up like a clinic. The fire stations are closed due to the pandemic, but I think it could complement an effort at a clinic-based level, or the marketing strategy could, so that we can kind of, social media carpet bomb, if you don't mind that metaphor, the availability. Thank you.
Thank you, Chief Black. Sheriff Knoll.
Yeah, Anya, I wanted to tell you, good job bringing this up, and everyone said how brave you were. It really is brave to come forward with this stuff. I wanted you to know that all the deputies do carry Narcan in their vehicles and have administered it. Not every deputy, but it's been administered numerous times, and is actually, if you want to say, I would think, brought people back to life. And we have it in the jail too, in case something happens there. And just for what it's worth, I can tell you that all the people that are on this meeting and the people in my circle in Jefferson County, it is something that we want to make sure is available and whatnot. The other question I have was, and sorry for being naive, and maybe you already said this, but did you ever get your Narcan from the health department?
I did. I went to the clinic on Friday and just acted like a normal person and got it. I didn't say that I had a problem the other day. I just wanted to see how they, how it would go as a normal person. Yeah.
Okay.
And they were, and the nurse was great, and it was great. But I just still think that it should be more widely available. And especially when I heard what you just said, that you're only open on Fridays, don't change that flyer and don't change your website. Change your hours for there to be someone staffing the SEV clinic right now, because it's a COVID crisis, and we need to shift things around and make sure that there's more hours than even what was on that paper that was given to me.
Yeah, and I'm glad you said that, Anya, because that's something that came up in our discussions, is that it doesn't really have to be a nurse that runs the SEP clinic. We've always just had it as a nurse who runs it. But there's many SEP clinics that nurses don't run. It's just trained professionals to do it. And so, that was something that came up also. And, we kind of run things around here on a bit of a consensus decision-making model. And so there's a lot of people who are involved in making the decisions and creating the policy. There's a lot of voices involved in that. And so sometimes that takes a little longer than is comfortable, that kind of process. And so, yeah, these are definitely all things that are on our table. And I'm really saddened to know that our website and that schedule are inaccurate. Yeah. So thanks for looking great.
I wanted to add one more thing. Sorry. Just for what it's worth, I'm surprised that anyone in Jefferson County would ever not have trouble getting Narcan. So something messed up somewhere, and
we're gonna fix it.
Yeah.
Yeah. Lisa.
Yeah, and I'm sorry, Lisa, I'm sorry I jumped in. Joe, thanks for saying that, because as the coalition coordinator for for the Jefferson County Empowered Teens Coalitions, we made sure that Quilcene School District, Chimacum School District, Port Townsend School District all had Narcan, so that, and then we trained all of the people who were chosen at the school districts to learn how to use it, and so it's accessible to for an emergency use at the school, just like an AED is. And so yeah, Joe, thanks for saying that. And sorry I interrupted you, Lisa Ray.
No worries, thank you. First of all, I want to express my gratitude for all of your solutions and compassionate, focused approaches to the work. And Anya, yes, it was courageous and it was also very loving. So thank you for that. And you too, Denise, for problem solving. We have Allison Newman at ADI, the Addictions, Drug and Alcohol Institute, who I can connect you with her, and you guys can work together if you want to strategize how to take all these great resources that we've just heard about and connect them, and then connect them to the community. It's what she does. It's one of the things that she does. She's fabulous to work with. She runs our stopoverdose.org work.
Oh, great. I definitely will be connecting with her. Maybe Anya, myself, her can come together and take it from there, because it sounds like what we could do is work something where we're at the consortium table, we create whatever it is, and then it's just angled for the fire department so they can use it in their venue in a way that suits their audience and across the board. So thank you, Lisa. That's good to know. James.
Hi, so one of the roles that I also have in the county is county coroner, and no, I don't actually have any qualifications for that job. It's just tucked into the prosecutor's office by statute. So thank you, Washington legislature, from over 100 years ago. But what it does do is it does give me visibility on overdose deaths that come into the county. And one of the things that I have to admit I've been a little frustrated with is, we were talking about the opioid epidemic before COVID came along, and COVID basically took all the wind out of those sails, but the opioid epidemic didn't go away during that time. It got worse. And I do get weekly notifications from the King County Medical Examiner's Office. It kind of gives me a little bit of an insight on tracking overdose deaths, and 2021 is just off the charts. And so I'm glad that we're, bringing some visibility back to this subject matter. I was previously under the impression that Narcan or naloxone was fairly widely available in this county, but it sounds like we still have some work to do. So thank you to Anya for coming forward with your story.
Thank you. Cherish.
Yeah, I have to say, when I first got here, I was really surprised, because coming from Dayton, Ohio, we handed out Narcan and naloxone like it was candy. I mean, everyone at the agency had a box in their drawer, because we never knew when somebody was coming in for services who would, be experiencing an overdose right there or in our parking lot. I had a painter one day at the agency who was there to paint our walls one weekend, and he went down on me. Luckily, I saw him on the security camera and brought him back. But when I got here, I asked the staff, I was like, well, where's my box of Narcan? And nobody had it. And I was like, well, what do you mean nobody has it? And then somebody was like, well, we're not trained. And I was like, well, do you know how to spray something off somebody's nose? Like, it's not, And so, yeah, and we didn't have any at the shelters. So I was freaked out about that. So, most recently, somebody else, who does substance abuse stuff gave me 4 boxes. And, that's the first time that somebody's physically handed over boxes to me. And I've just been surprised because, as the homeless provider, as the social service provider, I just expected we'd have some around. But the staff, essentially told me, well, there needs to be training, or they watch how much they give because of the expiration dates. And it was just one of those things. Since our doors were closed, I didn't push the issue. But it's been surprising to me how little I see it here versus when I was in Dayton, it was everywhere and available. So I know we want to be smart about not giving out more than what's going to be used, or, watching expiration dates. But by the same token, like you've already bought it, you already have it. You might as well, make sure it's in the hands of the providers that need it. So, so those of us that deal with that population a lot, I would expect, my staff to be able to respond in a heartbeat,
So it sounds like we, as a result of this conversation, see some real opportunities. There's at the base level, fix the website, figure out what we might do better, more at a clinic level that would allow us to get more out there, have it more easily available and accessible. There's the idea around marketing and how we can get the message out. And then it sounds like there might be this broader question of how can we make sure we've got a naloxone supply everywhere it makes sense, like at an OECAP office. And so those are 3 things that I see. Is there anything else that you guys would like me to add to that list that we think about, go off and work on between now and the next meeting? Okay. I want to just bring it back to the Behavioral Health Consortium and why we sit at this table. And I wonder if there's somebody who can tell me, why is it important that we just did this exercise? What was the value of it in terms of the mission of this whole table?
Because we take care of all people. I don't know. It's all important.
I think that's valuable. That's really valuable.
I think that, all of us touch, we all overlap. When you look at, the circles, right? And you put all of our circles on here, we overlap in a lot of areas. And it is important from all of our various perspectives to know how messaging is going, how, these important matters are being handled, and to be okay with saying, like, hey, the way we were doing this wasn't working. It's like I tell our staff all the time, just try something, it's okay. Like, and if it doesn't work out, we'll try something different. There's no harm in at least trying something and finding out whether or not that's working or not. So being open and not, pointing fingers, and just knowing that we're all here to support each other and lift each other up in this work, I think is important.
I agree with Cherish, and given the Behavioral Health Consortium's mission and vision statement, I think that this is absolutely applicable. And also what it helps folks do, perhaps, is that having Anya given us the opportunity to look at our policy, it helps us recognize, oh, this is somewhere where we've not given this proper consideration, because we would never want to stigmatize anyone. We're working toward destigmatizing in all sorts of areas, along with substance use disorder. And also then to do this in a public forum gives other agencies the opportunity to say, where might we be doing this? Where might we be, having policies that are underexplored, that we've underexplored the consequences of, that we have unforeseen consequences within them, we have unintended consequences in them, that kind of thing. And so to Anya's point, where she said, the resources on a website should talk to people who have substance use disorder. They shouldn't just talk to people who are professionals in the service world. You know, I think that that's very accurate. And so, yeah, that's why I think we did it.
So I've been through a lot of meetings in going on my third year here, where we talk about a lot of things. And I see the BHC as a meeting that has extreme importance because we have a lot of key stakeholders here. So the question is, how do we come together when we see a problem like this or identify an issue? How can we collaborate better and actually take an action to do something? Because I can go to a lot of meetings and hear about all these things, and then that's nice, or trainings that are coming up. But where's the action that takes this? You know, where can we find a way that, okay, we identify we have a problem that this young lady came here and told us about, and it needs to be resolved. And the question is, what do we do from BHC? I think this is the foremost committee or group in Jefferson County that comes together and talks about substantive issues. And the question is now, how do we move those issues forward? And I'm sitting here thinking, I just remember reading an article a little while ago, Wenatchee has got a machine down there. It's like a soda machine that dispenses Narcan. OMAC, where I used to work, they're going to put that same machine in the FQHC lobby starting next year to make it access. So maybe several of us, and I'll take the lead, take a look, how do we get one of those, and what does it take to do something like that, to have those kinds of distribution centers? But I think this is a committee that's really important, that has to do the hard work of really changing how we respond to things in this county. So that's my soapbox for the day, but I really feel important about that. So
it's a good soapbox, and we'll go away between now and the next meeting and see if we can come back with some real actionable things that give you guys a chance to react to them and help us refine, so that we actually do something about what has been unfolded here and the opportunity we've had to discuss it. I'm going to close out this piece of the agenda unless there's anybody else who would like to speak to it.
I would just like to say that Aimee put in the chat that this conversation is related to the deaths of despair that she wanted to talk about too.
Oh, yes, yes. And so I'm going to turn the program then over to our data sharing piece, which Aimee will be talking. She can tell us a little bit about that article if she'd like. I recognize we're at 3:48, so we're going to bomb through this quickly. Let me just share my screen. And get down to, and then Aimee or Lisa, you just tell me when you want me to advance slides and I will try to do that for you. I think Aimee, you might be muted. Aimee, I think you're.
Sorry.
Thank you.
So as Lori mentioned earlier, this is a update to the data that we provided back in October. There was a request at that meeting to put some of the data in context. What % of calls, or what is the burden of behavioral health calls on different agencies across the county? Additionally, we've got some data that we received from Believe in Recovery and Gateway to Freedoms programs that we failed to include in our last update. And so we want to apologize for that and present that data as well. So this data here is looking at % of behavioral health calls for Townsend Police Department over the period of time that we looked at. So that ranged between 6 and 9%. The percentage was growing between September and May, and it's been on a downward trend since May, although there was an uptick in August. We can go ahead, please, Lori. So to put the previous slide in context, about 85% of calls were related to mental health, with approximately 34% of calls having a substance use disorder component. This is looking at behavioral health encounters in the emergency department. About 10% of calls back in September were related to behavioral health, and that percentage has been decreasing over the past few months. As you can see, a larger percentage of patients are were visiting the emergency room for behavior or for mental health issues. And that percentage has been decreasing as well over the time. So as we saw previously, the percentage of ED encounters related to behavioral health is decreasing. Related to behavioral health has kind of decreased over the period, but volume has been relatively stable. So looking at those who are arriving in the emergency department for behavioral health concerns, a majority of them are arriving not by ambulance or not from a law enforcement agency. This is giving, this indicates there may be an opportunity to intervene prior to a crisis situation for either behavioral health or mental health or substance abuse scenarios. Looking at the jail, the percentage of bookings related to drug and alcohol charges has decreased over the past 12 months from a high of 71% in September down to 43% in August. MAT inductions over this period have been variable. And interestingly, one of the things I see in the data is nearly 50% of bookings reported a substance abuse problem in January. So although the number or the percentage of bookings related to drug and alcohol charges have decreased, nearly 50% in that particular month were reported having a substance abuse problem.
I'm sorry if I could just add to that. I don't know.
Absolutely, please.
I don't know how much of the, if there's been any change because of the Blake decision, because I know we're not arresting people like we were before for drug possession. So I don't know how that will pan out, but I just wanted to throw that out there.
Thank you. So this is a table that just had the numbers from the previous slide, so I don't think we'll spend time on that slide at the moment. This slide is looking at Jefferson County Sheriff's Office encounters related to behavioral health. The percentage of calls for Jefferson County is about half of what it is for Port Townsend. And similar to Port Townsend, we saw that peak back in May with a decrease over the past few months, down to about 2% in August of 21. I think we hypothesize it's related to the types of encounters that Jefferson County has more frequently related to traffic stops. And so that's why it's a lower percentage than Port Townsend. This slide has some additional data. When we presented the last data, we didn't have the September through February data period. And so this is adding to that data. One of the findings we pointed out last time is there's been a pretty dramatic increase of calls related to mental health. And that trend is holding true when we're looking back to that September time period. Between the September 2020 and February 2021 time period and the May 21, August 21 time period, behavioral health or mental health calls, I'm sorry, have more than doubled over that period of time. This data is from East Jefferson Fire and Rescue. Similar to Port Townsend, between 5 and 9% of calls are related to behavioral health. Like we saw with Jefferson County and with Port Townsend, that number peaked in the May-June time period and has been decreasing for the remainder of the months. As I mentioned earlier, we had failed to include data that we had from Gateway to Freedom and Jefferson County Jail in our previous update. And so this is just looking at that data. So 93% of inmate assessments were referred for inpatient substance use treatment, while only 7% were referred for outpatient substance use treatment. And these inmates required referrals to a wide variety of social services. And finally, again, this is new data, Believe in Recovery. Of the clients that were screened for substance use disorder by Believe in Recovery, about a third were diagnosed with alcohol use disorder, about a third with opioid use disorder, slightly less for methamphetamine use, and only about 8% for other types of substance use. And what is very exciting is 100% of Believe in Recovery clients that have had MAT services, receiving MAT services, have been receiving those for 3 or more months without interruption. So that is just pointing out the great work that Believe in Recovery is doing in the community.
I know we bumped through that data very quickly. There are some questions that Lisa and Aimee and I talked about. I don't know if either one of you want to talk about just some of the highlights that we made as we were looking at that data and asked ourselves if maybe we should think about it in one way or the other. And then of course, if there's somebody else who thought of something as we were going through the slides, I'll open it up. Go ahead, Lisa.
Hey, yeah, one of the things we talked about is the request was to put this data in context, because when you look at just behavioral health incidents, we're talking just about those incidents. So we could say 80% were mental health and 20% were something else. But what we don't know is what's the burden on the agency overall. And so when we got the data back showing like 1 to 3% for some people, it was a little, I felt like it probably didn't give the right picture. And so we really wanted to drill into that more. What should we be looking at when we're trying to figure out what the burden is to some of these agencies? Is it another cut on the data where we look at just non-traffic incidents, or is that even the point? We just wanted to make sure that we were really thinking through what that meant, not dismissing it like, oh, it's only 3%, so it's not an important variable. And then the other thing that I thought was interesting related to the ED data, because we've talked a lot about kind of what we're talking about today is how does everyone interact and intertwine, and in what ways can we figure out when this data is duplicating, not duplicating. And we've had a real sense, I think, a lot of times that probably a lot of the people that they're encountering in the field are the same people that are ending up in the ER. But then when you look at some of the ER data, it looks like that's not necessarily always the way they're getting there. And so there is some population we maybe isn't as duplicative as we thought. And so it just, I think we've talked on and off about having another kind of data drill down meeting to talk about how are we identifying people? Because I know we've talked about this before. Some people, I mean, some agencies are doing top of the mind. So what's the top issue they're dealing with that day? So it might be they're saying it's mental health, but they have serious SED issues, but that wasn't the issue of the day, of the interaction they were having. And other people are trying to figure out how many have co-occurring issues. And so just trying to figure out what this data is really telling us and to make sure that we're not making any assumptions about it based on some of the percentages being different than what maybe we were expecting. So that was.
Thank you.
Did that cover most of what you think we talked about, Lori? Or?
I see Dr. Carlbaum has a question or a thought.
Yeah, I think just a comment. I think it's an opportunity for us to step back and look at the inputting of the data. I think, there's so many variables, like you just pointed out, Lisa. So if the firefighters, EMTs are seeing someone who is suicidal and cut themselves with a knife, it may be coded as a laceration, and suicidal ideation may not show up in that chart. And so I wonder about that. And so it's probably an opportunity to start to step back and use both primary impressions but secondary impressions, and better provide guidelines for providers in the field, either in the ED or in the streets, to better capture, because I worry that we're under capturing things.
Mm-hmm. So I hear two things. There's the under capturing, just maybe in terms of how it gets coded. And then there's also, perhaps we need to look at, for instance, a traffic stop, while it is a call that shows up as a call or as an encounter, it's a different sort of resource intensive thing that goes on than a stop that, or than an actual mental health or opioid or substance use sort of a call. And so I think what we need to do is gather the folks who are working on data, the agencies that are working on data specifically, together and have a data subgroup meeting, sort through that a bit. And if it's all right with you folks, I think I'd like to set that up sometime between now and the next meeting. And then we'll come back to this group with what we're trying to look at more tightly. And then remember also that the next data the next 6-month data is going to be due in March. And so whatever we come up with probably won't be entirely reflected there, but hopefully in subsequent views of this data at the next 6-month increment, we'll begin to see some tightening of what we're looking at. I want to thank everybody who gave us data. I want to thank Anya for being here and for walking with us while we listened and learned, and Denise for being straightforward and honest about how the experience was, and wanting to get it right, because I know public health really does want to get it right. Everybody at this table does. And I think that's all I have. Anybody else before we say goodbye? All right, go forth. Have a great evening.
Thanks, Lori. Thanks, everybody.
Bye-bye.
Take care.